Abdominal trauma is defined as injury anywhere between the nipple line and inguinal creases and can be blunt, like from motor vehicle accidents, or penetrating, like from stab wounds or gunshot wounds. As with any trauma, evaluation begins with the primary survey, which includes the ABCDEs: airway, breathing, circulation, disability, and exposure. The main goal of the primary survey is to assess and treat for immediately life-threatening injuries. Okay, so if the individual is talking to you with a clear voice, their airway is intact. If not, assess their ability to maintain the airway, or if they need assisted ventilation with a bag valve mask or even endotracheal intubation. As for breathing, look for tracheal deviation and listen to the breath sounds. Also, if the individual is hypoxic, provide 100% oxygen using a non-rebreather mask. Next, look at the heart rate and blood pressure, as tachycardia or hypotension may indicate hemorrhagic shock. Assess for signs of inadequate end-organ perfusion, such as altered mental status, decreased urine output, cool or pale skin, and delayed capillary refill. Also, insert 2 large-bore intravenous lines and prepare for the need for blood products. Bedside ultrasound can also be used in the primary survey, and it's called focused assessment with sonography for trauma, or the FAST exam. The ultrasound probe explores the pericardial cavity, then the right flank, also called the hepatorenal recess or Morrison's pouch, and then the left flank, which looks for perisplenic fluid, and finally the suprapubic region to look for fluid around the bladder. When views are added to look for a pneumothorax, hemothorax, or cardiac tamponade, it's called an extended FAST or EFAST. The FAST exam is non-invasive, portable, and great at detecting intra-abdominal bleeding, but it does require skill to use it properly and doesn't identify which organ is injured. For example, fluid in the hepatorenal space does not necessarily mean hepatic injury. Finally, there's disability, which means neurological disability and is assessed by checking the pupils and using the Glasgow Coma Scale or GCS. And there's exposure, which is assessed by turning the individual on their side and assessing their back for any occult injuries. Now, the secondary survey focuses on taking a history and performing an elaborate head-to-toe examination with the goal of detecting more subtle injuries. Ecchymosis over the periumbilical region, also called Cullen's sign, or on both flanks, also called the Gray-Turner sign, respectively signify intraperitoneal and retroperitoneal hemorrhage from pancreatic injury. Referred pain to the left shoulder when palpating the left upper quadrant is Kerr's sign, which indicates splenic injury irritating the left hemidiaphragm. A seatbelt sign is a diagonal ecchymosis across the abdomen in the distribution of a seatbelt, and this clues towards small bowel injury or a transverse fracture of the L3 vertebra, also called a chance fracture. Signs of peritoneal irritation, such as guarding and rebound tenderness, may be present, but the absence of these findings don't rule out an abdominal injury. Common labs that are sent include a CBC, blood type and cross-match, and a PT, PTT, and INR. Also, a urine beta-HCG should be obtained for any female of childbearing age. A urinalysis should be obtained to look for hematuria, which could be due to genitourinary injury. And because bleeding from trauma causes a loss of platelets and coagulation factors, in addition to a loss of red blood cells, it's important to replace them all. So, packed red blood cells, or PRBCs, platelets, and fresh frozen plasma, or FFP, are all given in a 1:1:1 ratio. In other words, if you're giving 3 units of PRBCs, you'll also give 3 units of platelets and 3 units of FFP. Additionally, because gram-negative and anaerobic bacteria live in the gut, prophylactic antibiotics like piperacillin tazobactam are given to decrease the risk of an intra-abdominal source of sepsis. Management of blunt abdominal trauma depends on the individual's hemodynamic stability. If they're hemodynamically unstable and the FAST exam shows free fluid, they should immediately get an exploratory laparotomy. If the FAST exam doesn't show free fluid, then resuscitation is continued, and other causes of hemorrhagic shock should be searched for, like bleeding from a pelvic or long bone fracture. After that, the FAST exam is repeated, and a diagnostic peritoneal lavage, or DPL, can be done. A DPL involves inserting a needle into the abdomen, aspirating a fluid sample, and sending it off for microscopic analysis. In a hemodynamically unstable individual, if there's gross blood, or more than 100,000 red blood cells, or more than 500 white blood cells on the microscopic analysis, then an exploratory laparotomy should be done. Now, if the individual is hemodynamically stable, and their FAST exam is negative for free fluid, then serial abdominal exams are performed every couple of hours. Some individuals are sent for a CT scan of the abdomen, depending on the clinical suspicion of intra-abdominal injury. On the other hand, if the FAST exam shows free fluid, then the next step is definitely a CT scan of the abdomen. The CT can show specific organ injuries, as well as retroperitoneal injuries, but it can miss pancreatic, diaphragmatic, small bowel, and mesenteric injuries. If the CT scan is positive, then the next step is either non-operative management or an exploratory laparotomy, depending on the type and severity of the injury. Alright, now in penetrating abdominal trauma, the primary and secondary surveys are similar. Also, the FAST is routinely performed, but unlike blunt trauma, it's less helpful and isn't used in isolation as a reliable decision-making tool. It's also usually done as an EFAST exam because the concern for pneumothorax or hemothorax in penetrating trauma is greater than in blunt trauma. Another difference is that individuals with penetrating abdominal trauma should receive a tetanus toxoid vaccine. Prophylactic broad-spectrum antibiotics are typically given to those that need surgical intervention. Finally, if an object like a knife is impaled, it's important to leave it in place until it can be surgically removed to prevent uncontrolled bleeding. Okay, now when it comes to stab wounds, the liver is the most commonly injured organ. An emergent exploratory laparotomy should be done if there's hemodynamic instability, impalement or evisceration of abdominal contents, signs of peritonitis such as guarding or rebound tenderness, or signs of gastrointestinal hemorrhage such as rectal bleeding or a bloody aspirate from a nasogastric tube. If none of these are present, then the next step is to determine if there's penetration into the peritoneal space, specifically if the anterior rectus fascia was penetrated. This can be done with a FAST exam, which will show free fluid, done in conjunction with exploring the wound under local anesthesia. If there doesn't seem to be peritoneal penetration, then the wound should be cleaned and closed. If there is peritoneal penetration, a CT scan is done to delineate specific organ injuries. Then, the individual is observed for 12 to 24 hours, and during that time, serial abdominal exams are done every few hours. If they develop hemodynamic instability or signs of peritonitis, they're taken for an exploratory laparotomy. If the individual remains hemodynamically stable, doesn't develop signs of peritonitis, and is otherwise stable, they're typically discharged home. Okay, now for gunshot wounds, the small and large bowel are most commonly injured. Indications for emergent exploratory laparotomy include hemodynamic instability and signs of peritonitis or evisceration. If none of these are present, then assessment for peritoneal perforation is done using a CT scan. Now, unlike stab wounds, gunshot wounds almost always penetrate the peritoneum and cause intraperitoneal organ injury. If there is evidence of peritoneal penetration, then an emergent exploratory laparotomy is done. Rarely, if there is no peritoneal penetration on CT, the individual is admitted for serial abdominal examinations, and if they're hemodynamically stable, have no signs of peritonitis or other injuries, then they're discharged. Alright, now let's talk about some specific organ injuries. The spleen is one of the most commonly injured organs in both blunt and penetrating abdominal trauma. Diseases that cause splenomegaly, such as infectious mononucleosis, predispose to splenic injury, even if the traumatic event was mild. A CT done with IV contrast can show blood collecting around the spleen, an intraparenchymal or subcapsular hematoma, or a contrast blush, which describes hyperdense areas within the spleen which occur due to leakage of contrast material through injuries to tiny blood vessels. Splenic injuries are graded 1 through 5, where grades 1 and 2 are considered minor injuries, grade 3 is a moderate injury, and grades 4 and 5 are severe injuries. Individuals with grade 1 through grade 3 injuries are managed non-operatively with serial abdominal exams and hemoglobin measurements. Additionally, if contrast blush is seen on CT, an angiographic embolization of the splenic artery may be needed. This involves introducing a catheter into the femoral artery, then into the celiac artery, and then occluding the splenic artery to stop the bleeding. If there's evidence of ongoing hemorrhage, or if there's a grade 4 or 5 injury, then a splenectomy is the next step. Because asplenic individuals lose their immunity to encapsulated organisms, pneumococcal, meningococcal, and Haemophilus influenzae type B vaccines are given prior to discharge. Similar to the spleen, the liver is a big target for injury in both blunt and penetrating trauma. An abdominal CT with IV contrast can show the same sort of findings found in splenic injury. Hepatic injuries are graded 1 through 6, and individuals with blunt hepatic trauma are managed non-operatively regardless of the injury grade. Once again, angiographic embolization can be done if there's evidence of contrast extravasation. Failure of non-operative management is an indication for surgical management. One operative technique to control liver bleeding is the Pringle maneuver, and that's where the portal triad is occluded using a finger or a vascular clamp. Trauma to the gastrointestinal tract is also called a hollow viscous injury. CT findings include pneumoperitoneum, which is free air in the peritoneum, bowel wall thickening suggesting a hematoma, or free intraperitoneal fluid in the absence of another solid organ injury. Gastrointestinal injury is usually managed surgically, either by repairing or resecting the injured bowel segment. The viability of a bowel segment can be determined intraoperatively by injecting intravenous fluorescein dye and looking at the bowel under a Woods lamp. Non-viable bowel segments will not light up. Duodenal injuries are usually a result of penetrating trauma, and CT scans tend to miss them. Therefore, if a duodenal injury is suspected, an upper gastrointestinal series should be done with a water-soluble oral contrast such as gastrographin. Leakage of the contrast from the duodenum indicates injury. A large duodenal hematoma may obstruct the gastric outlet, causing severe projectile vomiting. Once detected, duodenal injuries are treated surgically. Near the duodenum lies the pancreas, which can also be injured in penetrating trauma. An elevated serum or DPL fluid amylase level suggests that there may be a pancreatic injury, but it may be due to a general inflammatory response which often occurs after traumatic injury. The diagnosis is usually made with CT, and injuries are graded 1 through 5. Grade 3 to 5 injuries require surgical intervention. Lower grade injuries require endoscopic retrograde cholangiography to look for pancreatic ductal injury. Those without ductal injuries can be managed non-operatively, while those with ductal injuries require surgical intervention. Now, regardless of the cause, fluid or blood collecting in the peritoneal cavity or the retroperitoneum can lead to abdominal compartment syndrome, which is organ dysfunction caused by increased intra-abdominal pressure. This pressure causes decreased perfusion of abdominal organs, resulting in organ ischemia. Additionally, due to compression of the inferior vena cava, venous return decreases, causing cardiac output to drop, worsening the ischemia. Diagnosis is made directly by measuring the bladder pressure with a Foley catheter that has a pressure transducer. A pressure greater than 20 millimeters of mercury plus organ dysfunction indicates abdominal compartment syndrome. Management includes limiting fluid resuscitation and decompressing the stomach and bladder with a nasogastric tube and a Foley catheter. Definitive treatment is performing a decompressive laparotomy. Alright, as a quick recap. Abdominal trauma can be blunt, like from motor vehicle accidents, or penetrating, from stabs and gunshot wounds. Initial evaluation starts with the primary survey, or the ABCDEs: airway, breathing, circulation, disability, and exposure. The FAST exam is now part of the primary survey, and is aimed at identifying free fluid in the peritoneum. In blunt trauma, a hemodynamically unstable individual with positive FAST should go for emergent exploratory laparotomy. If the individual is hemodynamically unstable but the FAST is negative or inconclusive, then resuscitation should continue, and a diagnostic peritoneal lavage or DPL is performed. If they are hemodynamically stable and the FAST is positive, a CT scan with IV contrast is performed to detect specific injuries. If the FAST is negative, then the individual can be discharged, or a CT scan may be performed depending on the clinical suspicion for injury. As for penetrating trauma, indications for an emergent laparotomy in stab wounds include hemodynamic instability, peritonitis, impalement, evisceration, or gastrointestinal hemorrhage. If absent, peritoneal penetration is assessed by a FAST exam, or more accurately, local wound exploration. If there's no peritoneal penetration, then the wound is cleaned and closed, and the individual is discharged. If there is peritoneal penetration, the individual is admitted for observation, serial abdominal exams, and a CT scan. As for gunshot wounds, indications for emergent laparotomy include hemodynamic instability, peritonitis, or evisceration. If absent, a CT scan is done to look for peritoneal penetration. Since most gunshot wounds penetrate the peritoneum and cause visceral injury, a laparotomy is usually done.